So this is the first episode of the second season of Medicrew Masterclasses, and today we are going to discuss the physiology of speech production and the disorders of speech. As usual, we will always start with a few multiple choice questions, and I would welcome everyone to answer them. And once the questions are answered, we will start with discussion based on those questions and get back to the questions at the end of the session to see whether we were right or wrong. So here we start with the first set of questions. The sound produced by the human larynx is called. Here comes your second question. Language is based on. The third question. When a person speaks, her ears help in feedback regulation. Is it true or false? Next question. So there are 4 statements regarding the function of the speech areas. You read all of them carefully and choose the true or the correct statement. And the final question before we start the first part. If a person comes with poor comprehension, fluent speech, and poor repetition function, then what is that person suffering from? Okay, so with this we start the first part of the webinar, which is about the physiology of speech production and the abnormalities of speech production at the level of the brain, which is called aphasia. The second part, which we will start in the second half of the session, is about the output of the speech, and we will talk about dysphonia and dysarthria. So let us start. There are 3 very interconnected words when we talk about the language function. The larynx produces sound, and the sound does not necessarily mean meaningful sound. There are babyish blabbers. We also grunt in pain. So all sounds do not necessarily lead to speech and language. But any sound that is produced by the larynx is known as voice or vocalization. So vocalization refers to production of any sound with the help of the voice box, that is the larynx. We also know that humans express thoughts, feelings, and ideas orally, that is verbally, to one another through a series of complex movements that will alter and mold the basic tone created by the voice. And that creates a specific decodable sound. So, for example, when we make illegible sounds like ah, that may not make any specific sense unless put into a perspective. But when that ah is modified into ah, and that in a context can mean a ball, a bat, and it can represent one. So the same crude sound that is produced by the voice box when put into a proper perspective and is expressed with the help of proper movements of the tongue, the teeth, etc., a proper articulation is produced. And then that is known as a speech. A speech is a speech only when the other person has an ability to decode that, which means we are using some preformed codes known as words in order to express the speech. And the formulation of these words by codification is known as language. So, language is the expression of human communication through which knowledge, belief, and behavior can be experienced, explained, and shared. And this is one of the highest function of the Homo sapiens. This sharing is based on a systematic, conventionally used signs, sounds, gestures, or marks that convey understood meanings within a group or community. So, for example, what we can conceive as a red fruit can be called an apple. So, the word apple is basically a code. And to those who know this code, they will always remember the fruit apple whenever we use the word apple. And when this word apple is created using sounds like a, p, l, then that becomes a speech. But when they are not coordinated, simple vocalizations like a, p, they just become vocalization and not meaningful speech. So it is a group of voices coordinated together that makes a speech, and the speech takes the help of the syntax and grammar of previously coded symbols, and these symbols are known as language. For example, English is a language. English refers to a dictionary of codes with which various meanings, various feelings, various objects, various activities have been represented with words. And when they are spoken out by the larynx in a coordinated way, they become a speech. So this is the basic difference between a voice, a speech, and language. There is a very interesting theory that was proposed by Dennis and Pinson in 1993. This is known as the speech chain. So what is the speech chain? On the left hand side, we have the person who is speaking, and on the right hand side, we have the person who is listening. So the chain is created between the speaker and the listener. Now look very carefully. The ideas originate in the brain of the speaker. These ideas are channelized through the motor nerves into the muscles of the vocal cord, the organs of articulation like the tongue, the palate, the pharynx, and ultimately meaningful sound comes out. When this meaningful sound comes out, it travels two ways. It moves towards the ear or the receptor of the listener. It is also heard by the same person who is speaking. So you also get a feedback of what you are speaking, and if necessary, you can correct yourself. So the feedback loop constantly reminds us or puts us into the context of what we are speaking. Whereas the traveling sound hits the other people's ear, create a series of events that are translated into auditory action potential. They then reach the brain and then they are decoded into meaningful substances, provided that they also know the code, which is the language. And therefore they understand what we are trying to say. Now, when the listener becomes the speaker, the speech chain will be reversed, and the same process goes on and on. In this whole speech chain, you will see the only part that is not biological is the transmission of the sound wave. That's a physical or mechanical phenomenon. But other than the transmission of the sound wave from the vocalization organ to the ear of any of the person, excepting for that part, Rest of the parts are all biological or physiological processes. And this interconnected physiological, physical and physiological process forms the speech chain. So I hope this is clear to everyone. Did you understand how the speech chain operates? Okay. So there are various theories of speech production. So there are very easy theories and there are some more advanced and complicated theories. What we will do is we will start with explanation of the most accepted easy theory. But then I will tell you the fallacies of the theory and gradually build up on the new theory of speech production, which is more clinically oriented. So if you go through the age-old theory of voice production and its translation into speech, then we land up in something like this diagram. We hear through the ears, and the auditory nerves ultimately terminate in a part of the brain known as the auditory cortex. And the auditory cortex, as you can see, is in the superior temporal lobe. Very close to this auditory cortex is a particular area of the brain, which has been labeled here as the Wernicke's area, after the name of the person who discovered this. So once we hear something, the auditory cortex tries to make an impression of what we have heard, and then the information is fed into the Wernicke's area. What does Wernicke's area do? Wernicke's area helps in reception and comprehension. That is, it helps in understanding what has been said. It helps in receiving the auditory input from the other person. And also interesting is the close anatomical location of the auditory area and the Wernicke's area, so that the information can instantly pass to the Wernicke's area. Once the Wernicke's area has been stimulated and the language has been decoded, according to the old theory, now this information passes down a tract of nerve fibers. This tract of nerve fibers is known as arcuate fasciculus. Arcuate means bent and fasciculus means bundle. So essentially it literally translates into a bent bundle of nerve fibers, and that's how it looks like. So from the Wernicke's area, the information goes to the area where the speech has to be now created by the listener. And this area is known as the Broca's area. So what do the Broca's area do? The Broca's area is concerned with the formulation of vocal response. Now, what does this mean? Formulation of vocal response. So suppose tells me, someone is asking me, in which class do you study? And my answer would be class 12. So when a person is asking me, in which class do you study? It's essentially a group of sound waves that are traveling to my ears. From the ear, the auditory nerve carries this information to the auditory cortex. The auditory cortex does not understand this, but the auditory cortex, quote unquote, listens to this. So we can hear the codes that have been spoken. In which class do you read? These words now vibrate in the brain like a sound box. That is what is happening in the auditory cortex. When information from the auditory cortex goes to the Wernicke's area, because of its previous exposure to the language, which is important, it can now decode the sentence. It understands what the sentence means. That someone is asking me the standard of my class. Then this information passes down through the arcuate fasciculus to that area which will now formulate the speech. Now, what is formulation of the speech? If you see, in the brain, this is the central sulcus. And in front of the central sulcus, there is an area. That is the precentral area. This precentral area is the motor cortex. And behind this, there is an area, the postcentral area. This is the sensory cortex. And in the motor cortex, different parts are responsible for different muscle movement. Close to the lower part are the muscles of phonation. That is the muscles that help in making speech. So this is that area. Now for the muscles to operate, you think of this like a synthesizer. In a synthesizer, you have to choose the proper instrument, that is the overtone. Then you have to play the proper sequence, that is the note, and therefore a proper sound will come out. So you have to know the notations and also choose the proper instrument. So by using the muscles of the larynx and pharynx, we can modulate the voice, that is like choosing the instrument. And then we can decide how they should move in order to produce certain syllables, to produce the answer class 12. So ultimately you are writing down a script, you are writing down a notation of voice. The notation will be played by the motor cortex, but the notation will be created by the Broca's area. So the Broca's area, when I say it formulates the speech, what does it do? It creates this entire manuscript of which muscle will fire first and which muscle will go next, which muscles will contract together and which muscles will not contract together. And this is a learned activity which we learn in early childhood when we learn to speak. And ultimately, when this manuscript is prepared by the Broca's area, the information goes down to the motor cortex, to the parts where there are muscles of larynx and pharynx, and ultimately our larynx, pharynx, tongue, teeth will move in a particular way so that we can speak. So I hope this is very clear to everyone. So I'm repeating this once again. When you speak, the words are identified by the auditory cortex. They are understood or comprehended by the vernix area. Then the question is transmitted to the Broca's area. Broca's area formulates the manuscript, the neural manuscript of the answer, and sends it to the motor cortex. Also see the close anatomical position between the Broca's area and the area of the motor cortex that controls the muscles of phonation. Very similar to how auditory cortex is so close to the vernix area. And ultimately the motor cortex is stimulated. It plays the synthesizer of voice, which is translated into movement of the larynx, pharynx, tongue, etc. And ultimately the voice output comes out. So vernix area helps in reception of the auditory input and comprehension, Arcuate Fasciculus in conduction of the impulse, Broca's area in formulation of the vocal response. And the entire model is here based on the spoken words. So is this circuit of spoken word clear to everyone? And of course, this is a very oversimplified old circuit model. Now, what about written words? If someone would have written on a piece of paper, in which class do you read, and shown this to me, then also I could have answered vocally that I read in class 11 or 12. So how do the spoken and the written words vary in their input? What is quite obvious is that if you see something, that will come via the optic nerve and not by the auditory nerve. So when you read something, the input is through the optic nerve. And we all know that the optic nerve will end in the visual cortex. The visual cortex is in the occipital lobe. This is where the primary visual cortex is. So when you see a question written on something, for example, now you are seeing this slide, you are reading it with your mind. That is actually you are reading it with your eyes. So your eyes have read this and sent the information to the occipital lobe, to the primary visual cortex. Now from here, there must be a way to reach the vernix area. But the problem is, vernix area does not take visual input. It can only take auditory input. It is like, for example, you have a CD-ROM player, but in your hand you have a magnetic tape. The magnetic tape will not play in the CD-ROM player. So first you have to convert the magnetic tape into a CD, and then the CD will play in your player. So a transformation in the code is necessary. So the visual code, which is like, say for example, the old magnetic cassettes, first this information will first feed into an area known as the angular gyrus. So this information from the area goes to the angular gyrus. The angular gyrus is an area which is like the transformer. It transforms the visual input into a language similar to language of the spoken words in terms of neurons. So now the angular gyrus has converted the visual information into something similar to an auditory information. So it can now be directly fed into the vernix area, and rest of the pathway remain the same. So angular gyrus essentially converts a visual input into something similar to an auditory input so that the vernix area can read the information. That means if the angular gyrus is not there, we will not be able to read, but we will be able to speak. So angular gyrus helps in reading words mentally without hearing. That is the function of the angular gyrus. And a second importance of the angular gyrus is also to look at objects and remember their names. So these two functions are attributed to the angular gyrus. One is the translation, if I can call this, or transcription of spoken input, transcription of visual input to spoken input. And the second important function of the angular gyrus is to name objects by looking at it. So in case if the angular gyrus is damaged, we will not be able to read things, but we will be able to hear and understand. Also, we will not be able to name objects properly. So this is the age-old model of speech which has been retained for a long number of years. That there are two areas, vernix and Broca's, connected by the Arcuate Fasciculus, and one is the receptive or the sensory area, the other is the responsive or the motor area, and they are conducted in between by the Arcuate Fasciculus. So this is basically the old model of the action potential. So is this clear? So we will now see the modification of this model in light of the newer studies. The new model looks somewhat like this. So we still have the same vernix area, and the function of vernix area is to receive auditory input. So what vernix area does is to receive auditory input. And in case the input is visual, we need a intermediate area, that is the angular gyrus, which we already know. So in case that auditory input is not available, we have only a visual input. Then the visual input, like a written word, first feeds into the angular gyrus. So from the optic area, that is the occipital lobe, the information goes to the angular gyrus. And from the angular gyrus, the impulse is transmitted into an auditory-like input and goes to the vernix area. So in whatever way the question goes to the listener, the question is decoded at vernix area. So if in one word we say the function of the vernix area, the function of vernix area is more than just reception. The vernix area helps in comprehension as well as reception. So after we understand the question, the information can go in two ways. One way is the conventional arcuate fasciculus. And another major pathway, which is the new discovery, is that it can go to multiple areas of the brain, not just one area, which are known as association areas of the cortex. So based on what kind of information we are talking about, information can go, for example, to the auditory cortex, to the occipital lobe. It can go to the somatosensory cortex. It can go to the prefrontal lobe. So various parts of the brain have various functions. It will be very reductionist to think that we need only two centers to speak. It's not as simple as that. For example, I'll give you an example. If you ask me a question on history, and if you ask me the date of an event, and then you ask me, why do you think this happened? This is a very complex question. The question has to be understood by the vernix area, no doubt. But for the date, I have to retrieve certain eventful memories, also known as semantic memories. So I have to retrieve semantic memory from the part of the brain where semantic memory is stored. Otherwise, I cannot give you the date. Then you are asking me an analytical question. Why do you think this happened? To analyze, I have to use my judgment. And for that, I need my frontal lobe. So here the frontal lobe function also comes into play. Maybe while asking the question, you have touched my shoulder, indicating that you are not an aggressive person. You are asking in a friendly way. That has to be understood by the sensory cortex. And accordingly, I change the tone of my voice. I don't also answer aggressively. I answer politely. So many things are happening together, and that cannot be done only with two areas. So we need multiple areas of the brain working together. And these areas of the brain are known as the association areas of the cortex. So the information also goes to different association areas of the cortex, and the input from arcuate fasciculus as well as association area of the cortex ultimately give rise to the Broca's area. So now the Broca's area, we can flip the arrows to make it more meaningful. So the Broca's area now receives the input from the association area. It formulates an answer and feeds this answer to the motor cortex. So feeds this answer to the motor cortex. And this motor cortex, with the help of its nerves, will ultimately modulate the organs of speech and produce speech, produce a verbal response. So this is the new model. Then the question comes, according to this new model, what is the function of arcuate fasciculus if everything is done by these long pathways across the association area? Probably we have overestimated arcuate fasciculus. Arcuate fasciculus cannot convey all information from vernix to Broca's area. So at most it probably helps in repetition. So if I tell you a number which you without even memorizing can just repeat. Say for example, I give you a phone number and I ask you to repeat immediately. Most people will be able to repeat it, but will forget after 5 minutes. This instantaneous repetition is a function of the arcuate fasciculus, not very intellectual, but yeah, it's important in certain cases. So arcuate fasciculus helps in repetition of words rather than transmitting all the information. The real transmission probably happens through bigger nerve tracts, elaborate nerve tracts that connect the association areas of the cortex. So this is the new model of the speech, and is this clear to everyone? Okay. So you see, what are aphasias? There are different kinds of dysfunction in language and speech. One problem may be that your brain is unable to produce language. There is no paralysis in your muscle. You have no paralysis of hearing. You can still see the question, but you cannot understand or you cannot formulate an answer. So when the problem lies in the brain, that is, the brain cannot comprehend or formulate answer, then that kind of a problem is called aphasia. But when the brain can understand, but your larynx has some problem, you cannot speak, that is known as dysphonia. So dysphonia is a problem with the voice. And when your larynx is giving out the output, but that cannot be modified by your tongue, teeth, and palate into meaningful words, then that is called dysarthria. It's a disorder of articulation. So aphasia refers to a problem in the understanding and generating response function of the brain. So it's essentially a higher function. Dysphonia is a voice problem and it deals with the larynx. And dysarthria is an articulation or pronunciation problem. So you can understand, you can produce voice, but the voice is not converted into proper speech due to certain disorders. While both dysphonia and dysarthria are mostly due to structural or neurological paralytic causes, aphasia is not due to that. Aphasia is due to failure of comprehension or failure of speech production at the level of the brain. So aphasia is more like a software problem rather than a hardware problem. So let us now understand what are the different kinds of aphasias. And before we start, let us quickly again summarize the functions of the different areas of the brain, and accordingly we can understand the features of different aphasias. So Wernicke's area helps in reception and comprehension. Association areas help in putting all information together and in a better comprehension. Broca's area helps in formulating the speech output. Arcuate Fasciculus only helps in repetition of word. So even meaningless repetition of word can be done by Arcuate Fasciculus. It probably does not help in transmitting understanding. It only transmits the sound, not the understanding of it. So with this new model, we will now start the discussion on different types of aphasia. To denote different aphasia, I will cut through various areas to show you which part has been damaged. So let us think first, the Broca's area has been damaged. And this refers to the first picture here. The shaded area is the Broca's area and the Broca's area has been damaged. Let us try to understand what will be the features of this. As the Broca's area is damaged, but no other area has been damaged. So you think carefully and tell me, the Wernicke's area is intact. So will reception and comprehension be disturbed or not? No. So there will be intact reception and comprehension. Second, now that the Broca's area is damaged, the patient cannot formulate a speech. So he or she can understand but cannot formulate things together to make a sentence. So will the person be able to speak properly? No. So when a person cannot speak properly, the person is said to be non-fluent. So there will be poor speech production or poor speech output. And in the language of neurolinguistics, this is known as that the person is non-fluent. Third, Arcuate Fasciculus connects the Wernicke's area with the Broca's area. So if any of these structures like Wernicke's, Arcuate or Broca are disrupted, then repetition is not possible. For repetition, the blue area, the yellow area and the red area all must be intact. So can this person repeat words? No. So repetition will be poor. So a combination of intact comprehension, poor speech output or non-fluency, and poor repetition, when these are present together, this is known as Broca's aphasia. These are then known as Broca's aphasia. I hope this is clear to everyone. That means the person has a damage to the frontal lobe of the brain. Now let us come to the second scenario. The vernix area is damaged. So we are dealing with the second picture here. See, a part of the temporal lobe has been damaged. So the vernix area is damaged, and let's go by the same parameters. Will the person's reception and comprehension be intact? Of course, no. So there will be poor reception and comprehension. There will be poor reception and comprehension. Second point, the Broca's area is intact. That means although the person cannot understand the question, the person can receive input from the association areas and answer something else. So I'm saying, for example, you can ask, in which class do you study? Of course, the person will not understand that because vernix area is damaged. But if the person wishes, the person can say, today's weather is a bit rainy and I'm not feeling good. So it will be an irrelevant answer, but at least he can formulate answers because Broca's area is there. This is known as spontaneous speech. So patient can speak on her or on his own, but not necessarily answering to your question. So can the person speak? That is my question. Whether relevant or irrelevant. So the patient is fluent. So the patient is fluent. Just a minute. So first of all, we see that the patient's comprehension is poor. The speech output is okay, so the patient is fluent. What about the repetition? Will the patient be able to repeat? Repetition is poor because we need the whole circuit to be complete. The blue area, the yellow area, and the red area. Here the blue area is damaged, although the red area and the yellow area are intact. So repetition is poor. So when this kind of combinations are present, that is known as vernix aphasia. I hope this is clear to everyone. Let us now try to understand what will happen if only the uh, arcuate fasciculus is damaged. So the vernix area is normal, the Broca's area is normal, but their connection is not normal. As vernix area is normal, will the comprehension be affected or will it be normal? So comprehension will be intact or normal. Will spontaneous speech be present or not? Spontaneous speech will be present, but that will be irrelevant. Spontaneous speech means what the patient is speaking, not necessarily answering your question. So spontaneous speech will be present. The patient is fluent. Although the patient is fluent, the patient is often irrelevant. And third, will repetition be present? So repetition is absent because the arcuate fasciculus has been damaged. When you get this kind of combination, you know that the problem lies with arcuate fasciculus. And that kind of an aphasia is known as conduction aphasia. This type of aphasia is known as conduction aphasia. So this corresponds with this image where the arcuate fasciculus has been damaged. Let us now talk about certain special types of aphasia. Suppose a part close to the Broca's area is damaged, but not the Broca's area itself. So Broca's area cannot send information or receive information, but it can still be connected with vernix with the arcuate fasciculus. So the damage is here. Let's assume what will happen. Will comprehension be intact or poor? In this situation, as the vernix area is intact, so comprehension is intact. Will the patient be fluent or mute? So there is a controversy you can see. You are not able to decide whether the patient will be fluent or mute. I'll leave this point and come back to this point. Will repetition be present? The repetition will be present. That means the arcuate fasciculus is normal. But now coming to the question, will the patient be able to produce an answer to your question? No. So there will be less speech production because the connection of Broca's with the motor cortex etc. has been severed. So patient can actually become slightly mute. Because I repeat, the key word here was the injury is not anywhere here. It's close to the Broca's area. That means maybe some part of the Broca's area is also damaged. But it is not the Broca's area itself that is damaged. It's like saying that a particular bulb has not been damaged, but the wire that is leading to the bulb has been cut. Then also the bulb will not be lit. If a fan is moving and the fan is not damaged, but the switch that operates the fan is damaged, then also the fan will not move. So you understand that the brain is a network of multiple neurons. It's not just one neuron, although we are drawing with one line. So the Broca's area is connected from multiple areas. The Broca's area is connected by the association area. The Broca's area is connected with the limbic cortex so that when you feel sad, you express the sadness. The Broca's area is connected to the somatosensory cortex so that when you pinch a person, the person will say ouch. Understand that this sadness, this pain due to pinching are not verbal words. They do not require the speech circuit, but they can still stimulate the Broca's area and take out sobbing noises or take out painful verses which are due to the pain or the suffering that the person is experiencing. And it does not have to be totally connected with the speech circuit. We don't always speak to someone. We can also speak to ourselves. We can also speak in a self-assuring manner. So that kind of speech will be present because Broca's area is still intact. But as the connection of the speech circuit is gone, the speech related part of the Broca's function will be gone. So is it clear to everyone? Why some amount of speech might remain? But if the Broca's area itself would have been damaged, it doesn't matter where the connection is lost. The Broca's function is lost. But here only the speech circuit is interrupted. Other inputs are not interacted. If you give an injection to the patient, the person will wince in pain because that is not a spoken input. That was a sensory input other than auditory input, and that can still take place. So that is why some speech will be there, so the patient will be slightly mute. And because the arcuate fasciculus is intact, repetition will be present. So whenever you see this combination where comprehension is intact, patient is mute, so these two things mean You are dealing with something like Broca's, but there is one thing that is exceptional. That is, the repetition is present. Once you find this, then you understand that the part involving the arcuate fasciculus is normal. So it cannot be directly Wernicke's or Broca's aphasia. It must be affecting some association fiber related to those areas. Then how do you know which area? As comprehension is intact. Therefore, Wernicke's area related structures are normal. Or as the speech is mute. So the part related to the Broca's area must have been affected. So we know that the damage is not to this part of the loop, but to the part of the loop connected to the Broca's area. So we will still call it a motor aphasia, but we will add one word to indicate that the damage is in the bigger part of the brain, and we call it transcortical, that is across the brain motor aphasia, not just on the Broca's area. Evaluation of aphasia is sometimes very difficult because most often the person cannot speak. So there are a battery of standardized psychiatric tests, which if I get time somewhere while discussing the psychiatric interview, I will tell you, through which aphasia can be interpreted. But probably with the modern technology, the best way to detect aphasia is by functional MRI. When you ask something to the patient and you see the nature of the blood flow in the different areas. If an area is not functioning, blood flow will not increase in that area. In a similar manner, if the damage now happens to this part of the circuit, close to the Wernicke's area, then the Wernicke's function will be partly affected, but other functions will be intact. So let's see, will the comprehension be normal or affected? The comprehension will be affected. Will the person be fluent or non-fluent? The person will be fluent. Because Broca's is working. Again, the answers may not be relevant, but at least the person can say something. Will repetition be present or absent? So repetition will be present. Again, you can easily deduce this. You see, as comprehension is affected, it must have something to do with the Wernicke's area. But had the Wernicke's area itself been damaged, then repetition would have been absent also. As the repetition is present here, therefore we say that it is not exactly Wernicke's aphasia, but it is transcortical sensory aphasia. The comprehension is affected because although I am showing the line here, please understand the problem can also be here. Like the speech input is going on, and when I say around the Wernicke's area, it can also be this. That is why comprehension can be affected. Now look into the diagram of transcortical sensory aphasia. So you see this is the area where there is Wernicke's area, and a part surrounding that area has been damaged. And you can not decipher from here whether it was an input fiber or output fiber directly. So probably input from the sensory areas like auditory or the occipital lobe are also affected. That is why comprehension will be affected. So what I'm again repeatedly saying is that this diagram is a simplified circuit and the brain is not as simple as this. Each one line here can represent multiple trajectories, which we are only simplifying and explaining in the form of a diagram. Again, if there are mixed kind of injuries, like multiple areas of the brain are damaged, then that will be known as global aphasia. So patients, all functions will be lost, and it's very difficult to evaluate such a patient. Or if both Broca's and Wernicke's area related areas are damaged, it can be a mixed transcortical aphasia. You can differentiate this from global aphasia by the fact that the repetition is still intact. And if none of these areas are damaged, but you see that the input from the angular gyrus is absent, which translates the visual stimulus into auditory-like stimulus, then the person will be able to understand and also respond. But the person will not be able to read, and the person will not be able to name something. Because the person cannot read, this is also known as word blindness or dyslexia. Lexis means to read. Or this condition is also known as anomic aphasia because the naming function is lost. So this is how the speech circuit can be damaged in different ways, and different kind of aphasias can result. Also understand one thing, as I understand from the questions in the chat box, understand that we are talking about comprehension of speech and output of speech. It is not only through spoken words that we always speak. We also speak in varieties of other ways. We speak with eye languages, we speak with body languages, we can speak with touch. So there are different ways of understanding language, interpreting language. We are only here presenting to you the spoken language circuit. So when I say comprehension is lost, it doesn't mean that comprehension to all sensory stimulus is lost. So there are windows of opportunity to talk to that person, to communicate with that person. So I hope this is clear to everyone. Now, because this apparently looks very complicated, so I will simplify this to you. There is a wonderful way to understand logically, not in a very mnemonic style, but in a more logical mathematical style, how to interpret aphasia. And this is done by something known as the aphasia box. So first understand what the aphasia box is, and then I think all of you will be easily able to understand how this aphasia can be interpreted. This is like a simple checker box. On the x-axis there are two options: good comprehension, poor comprehension. So you can understand we are talking of the Wernicke's area. On the y-axis we have fluent speech and non-fluent speech. So you can understand that we are talking about the Broca's area. And along the z-axis, this is a two-dimensional picture, so z has to be drawn like this. Along the z-axis, we have poor repetition and good repetition, and we are talking about the Arcuate Fasciculus. So with these three parameters, we can easily classify the common types of aphasia. Let's see if it works. Let's go one by one. Let's suppose that we are dealing with a patient with good comprehension, fluent speech, but poor repetition. Let's see where we end up. So good comprehension, fluent speech, poor repetition is the left upper half, this part of the circuit. So we end up here. And let us see if this is making sense. Good comprehension means Wernicke's area is normal. Fluent speech means the Broca's area is normal. But repetition is absent, means Arcuate Fasciculus is damaged. So we are dealing with conduction aphasia. In a similar manner, let's take another example. Suppose the patient has poor comprehension, fluent speech, but good repetition. So poor comprehension and fluent speech takes us to this quadrant. And because it's good repetition, we'll go to the right lower half. So the box tells you that the diagnosis will be transcortical sensory. The best way to learn this is to plot the types of aphasia yourself. And now see if it makes sense. It is poor comprehension. That means Wernicke's or its related areas are damaged. It is fluent speech. So Broca's and its related areas are normal. Now either the Wernicke's area is damaged or its related area is damaged. That can be determined by repetition. As the repetition is good, that means the Arcuate circuit is not damaged. So Wernicke's area is not damaged. So something related to Wernicke's area is damaged. Therefore, your diagnosis will be transcortical sensory aphasia. So you can actually take a screenshot of this and make use of this. Each time you make this diagram, you write down the type of aphasia yourself without memorizing this. That is a very nice way of understanding aphasia. And this is known as the Aphasia Box. So is it clear to everyone? So I'm taking another example before I move on to the next section. Suppose a person has poor comprehension, non-fluent speech. You can choose any three parameters, but poor repetition as well. Let us first think without plotting. Poor comprehension means problem is with Wernicke's area or its associated area. Non-fluent speech means problem is with Broca's area or its associated area. Now, if repetition is not there, the problem lies in the primary circuit, the linear circuit. If repetition is there, it's in the transcortical circuit. Here there is poor repetition, so problem lies with the entire circuit. Now see where we end up. So this person therefore will be having a problem with the Wernicke's area, a problem with the Broca's area. And you see that we don't really end up in one box. We choose this and we choose this. Both are applicable. So when these two are present together, what is your diagnosis? Global aphasia. Very good. So therefore your diagnosis will be global aphasia. This is how interpretation of this box is done. So now I hope that you will be able to practice this at home. Let us move to the next part, which is already explained, but again you can take a screenshot of this, and the whole thing that we have discussed is summarized here. This is an algorithm, and I will encourage that instead of memorizing this, you try to develop the algorithm. It's very easy to do. So the first question we are asking the patient is whether the patient can speak or not. Is the patient fluent or non-fluent? If the patient is fluent, then you ask about comprehension. And after comprehension, you ask about repetition. You see, we have only three questions. And all these three questions, when properly answered, will give you an answer. Let us follow a random pathway and let's see if we are right. Suppose the patient is not fluent. So we choose the answer no. Patient cannot speak. But can the patient understand? Like if I ask the patient that I am telling you a statement, if it is correct, you raise your hand. If it is not correct, you don't raise your hand. So that way also the patient can communicate and we can see if the patient can understand. So suppose the patient understands. That means comprehension is intact. So Wernicke's area is intact. Fluency is gone. So Broca or its related areas are gone. Now the question is the patient repeat? Can the patient repeat? So if the patient can repeat, the problem is not in Broca's, but Broca's associated area. So see, we have wonderfully landed up in the diagnosis. It's a transcortical motor aphasia. So this is also one way, and the best way to practice is you don't write the names of the aphasia, but instead you write down the algorithm and fill up the gaps yourself. That will be a very good conceptual exercise to understand different types of aphasia. So I hope this is clear to everyone. Wonderful. So before we proceed, let's go back to the questions that we started with. So tell me, the sound produced by the human larynx is called, what will be the answer? Wonderful. The answer is voice. Language is based on. Very good. All of the above. The sounds, the symbols, and the gestures. When a person speaks, her ears help in feedback regulation. Is it true or false? Next question. True statement is which one of the following? Very good. The true statement is Arcuate Fasciculus helps in repetition. Broca's area is not concerned with reception, it's concerned with motor output. Wernicke's area generates motor output is also wrong, it is concerned with reception. Angular gyrus is not important for comprehension, it's important for translating the visual impulse into a spoken like impulse. Finally, a person with poor comprehension, fluent speech, and uh, poor repetition has which of the following? Think logically one by one. Wonderful. The answer is Wernicke's aphasia because patient has poor comprehension, so the problem is in Wernicke's or in its associated area. Speech is fluent, so Broca and its associated area are normal. But as the repetition is poor, so the primary circuit has been damaged. Therefore, the problem is in the Wernicke's area, and this is Wernicke's aphasia. So up to this, I think everything is clear to everyone, and we can move on to the next section, that is the disorders of voice production and articulation. So let us start with some of these questions. The vibration of the vocal cords are best described as periodic, quasi-periodic, harmonic, or complex harmonic. Next question. Dysphonia in Reinke's edema in smokers is due to. Next question. Example of a bilabial English consonant is P as in pun, T as in ton, F as in fun, N as in none, and Z as in zen. Next question. Spastic dysarthria occurs in. And the final question of the session. Mixed spastic flaccid dysarthria occurs in. Okay, so let us understand the mechanism of speech production and articulation. This is something very interesting. So if we make a simplified circuit of phonation and articulation, what does phonation mean and what does articulation mean? When we want to make a sound, which is a voice, which will then be translated into a meaningful speech, the first thing is that air should come out of the vocal passage. The air comes from the lungs. So the lungs are essentially the bellows of the system that pumps air outside. It is like the bellow of any reed instrument like harmonium, without which sound will not be produced. Then as the sound moves out of the lung, it reaches the vocal cords. And it is in this vocal cord mainly that voice is produced. That determines the primary overtone that can distinguish my voice from someone else's voice. Very much like as it distinguishes a guitar from a sitar. Then that voice, as it is passing through the pharynx, the tongue, the oral cavity, the palate, and the nasal cavity and teeth. So when it is going out, it gives out the final output through the nose and through the mouth. And combinedly we get the output of spoken words or speech. This modulation of the voice into speech occurs in the whole tract starting from the pharynx up to the nose. All these organs can modify the sound. These are like the reeds of the harmonium that modify in what exact way, at what exact frequency, and also in what particular exact tone the sound is going to come out. And this is known as articulation. So as I was saying, we can compare the whole voice apparatus of the body with a musical instrument. The air that comes out is from the lung, which act as a bellow. The air flows down the vocal cords or the vocal folds, and the vibration produces the overtones, the characteristic voice of a person. And this is the voice or vocalization. When that voice passes down the pharynx, the tongue, the palate, the oral and nasal cavity, and the teeth and lips, it is modified into understandable codes, the language-based speech. And this process of modifying the sound is known as articulation. Therefore, a problem in the voice production, if the primary problem is in production of the voice, a hoarse voice or a low voice, then that is known as dysphonia. Because voice production is also called phonation. And a problem in pronunciation, in proper pronunciation, is known as dysarthria. Because the pronunciation is known as articulation. So whenever we talk about disorders of the voice, it is primarily a disorder of the vocal cords. And when we talk about disorders of pronunciation or articulation, it is a disorder related to either the pharynx or the tongue or the palate or the nasal or oral cavity or the teeth and the lips. So that is how anatomy of the speech is organized outside the brain. This is the peripheral mechanism of speech. So is it clear to everyone? Is this circuit simple enough to make you understand what it is? Okay. Satam, we do speak through the nose. When you use the uh, nasal intonations, you see that phonemically or phonemically, English is not very much phonemically arranged language. A better arranged language are the Indian languages, Bengali and Hindi. So when you go to the uh, nasal intonations, that is usually the fifth letter of every work that we have. So when you talk of ya, yo, na, ra, and ma, they are nasal tones. So you cannot avoid being nasal when you are saying something like 99. You are being nasal. And if you block your nose and say 99, what you get is known as hyponasality. And we will ask you, is your nose blocked? Do you have a cold? So nasal intonation is a part of the normal speech. If there is excessive nasal intonation, something which is known as the rhinolalia, then that is a problem. But a normal nasal intonation is always there in speech. So I hope this is clear to everyone. So phonation is the process by which the vocal cords produce certain sounds through a quasi-periodic vibration. Recent researches into the nature of vibration of vocal cord have made us understand that it is neither harmonic nor complex harmonic. It's not periodic, but the best way to describe the vibration of the vocal cord is quasi-periodic. So what is quasi-periodic vibration? Periodic vibration is something that repeats after a specific interval, every second, every hour, every 24 hour. And when the behavior is almost periodic with an element of uncertainty, because there are multiple variables working, then the oscillation is known as quasi-periodic oscillation. I'll give you an example. If the vocal cords would have been a simple instrument, which is just opening and closing as in the first diagram on the left hand side, it could have been a periodic motion. But if you think of the upper and the lower folds of the vocal cord and the activity of the cricoarytenoideus muscle, then the pulley system becomes more complex with multiple variables like that on the right hand side. And the vibration, although predictable, cannot be expressed as a single linear sine or cosine function. And therefore it is not harmonic or complex harmonic. Also, it is not in multiples of the same harmonic function. So a Fourier series will also not help. What you need is a Fourier decomposition of the whole waveform. And then you get the physics of oscillation. Without getting into such intricacies of physics, we can simply say that the vibration is not entirely periodic, it is almost periodic. It is close to the periodic one, but not quite periodic. And that is why it is known as quasi-periodic. The reason behind this aperiodic, unpredictable nature of the vocal cord is that different points of the vocal cord can vibrate independently because of attachment of different muscles. The vibrations can't be divided into simple harmonics because they affect each other. So they form very complex equations, non-linear equations, and therefore the vibration of vocal cord is best described as quasi-periodic or almost periodic oscillation. Any problem with this voice production mechanism is called dysphonia, and a major manifestation of dysphonia is hoarseness. Now, there are many causes of hoarseness, but from a physiological perspective, what can be the basic reasons for which a person should have a hoarse voice? Either there should be inadequate airstream, that is a problem of the lungs. This will not cause hoarseness, but this will cause a low volume speech, hypophonia. So the person will be whispering instead of shouting loudly. But true hoarseness can happen due to problems of the vocal cord, as we have seen. And the vocal cord can have three types of problem. A structural problem, that's called vocal cord aberration. A problem with its vibration, that is abnormal vocal fold vibration. Or a problem with its position. It can be abnormally abducted or adducted, and that is abnormal vocal cord positioning. Vocal cord structural problem can be due to many structural lesions like vocal nodules, leukoplakia, papilloma, squamous cell carcinoma. Abnormal vibration can be seen when there is edema of the vocal cord. In acute and chronic laryngitis, voice misuse, the smoking can cause a kind of edema known as the Rehnke's edema, which causes edema of the vocal cord, leading to an abnormal vibration. Laryngopharyngeal reflux or laryngotracheal reflux, where acid comes into the larynx, and in hypothyroidism, where the vocal cords become thick due to deposition of glycosaminoglycan. You can compare this with any string instrument like the guitar. The thicker the string, the hoarser or flatter the note. So gradually the voice becomes more flat and hoarse as there is edema of the vocal folds. Abnormal positioning of vocal cord is usually due to problems related to neurology. For example, there may be recurrent laryngeal nerve issues causing paralysis, or a broader spectrum of neurologic disorder like a stroke or Parkinson's disease that can lead to abnormal vocal cord positioning. So in summary, these are the physiological mechanisms of dysphonia. So are these clear to everyone? So now we come to pronunciation or articulation. So what is articulation? We saw that we can position the tongue, the palate, the teeth, the lip in such a way that specific syllables come out. This position or configuration of the vocal tract, the larynx, pharynx, oral and nasal cavity, resulting from the positioning of the mobile organs like the tongue, relative to the other parts like the teeth or the hard palate, this entire configuration of the vocal tract through which the sound is coming out is known as articulation. So any neurological problem or structural problem of these areas like the palate, the tongue and the teeth will lead to a disordered articulation or dysarthria. If you see the different parts of the articulatory apparatus, you can easily guess from the Bengali alphabets or the Hindi alphabets or the Devanagari alphabets how wonderfully and scientifically the alphabets are arranged. For example, when you go to the Pa Varg, the letters that you use by touching both the lips are the bilabials, like Pa, Ba. You cannot pronounce them without touching both the lips, so they are bilabials. Some of them are labiodentals, where the lip and the teeth play equal role. The labiodentals include fricatives, that is, husky noises like f, v. Also understand there are cultural differences between pronunciation. So any cultural difference is not a disorder, that's a learned trait. For example, in Bengali, we do not have f, we have paw. So you have pool to indicate a flower, and it's not fool. Pool is a bilabial because you cannot say ph or p without touching both the lips. But to say fur, you don't have to touch both the lips. You have to just put out the air through the lip and the teeth. It's a frictive. And therefore, the labiodental is fur, whereas a bilabial is paw. And the two pronunciations are different. So accordingly, the classification of the different phonetics are based on the anatomy of the phonetic apparatus, which is explained by the consonant phonemes, which I think is beyond the scope of today's class. But just to give you an example, a bilabial word, a bilabial syllable can be p or b, where both the lips are needed. Labiodental, where the teeth and the lip together blow out the air, f, v. A nasal bilabial is m. A glided voiced bilabial is w. Similarly, a glottal, which is also known as the contoborno or the sounds directly originating from the glottis. It does not require any kind of articulatory organ. They are all the vowels like and this consonant h. To say h, you do not need any other articulatory organs. Why is this knowledge important? It's not only important to learn grammar, it's important to understand ENT disorders. If you speak to a person for some time and you can analyze which syllables are damaged or missing in that person, you can at least guess from this chart which part of the buccal apparatus or the pharyngeal apparatus is damaged. So a very careful observation and speaking to the patient can land you up in an anatomical diagnosis if your place of articulation is totally clear. So is this clear to everyone? How this is related to the anatomy of the pharynx and the oral cavity and the nose? So a disorder of the articulation can be due to paralysis of any one of these. We know lower motor neurons, when they are damaged, they cause flaccid paralysis. So the tongue and the palate also become flaccid. So the pronunciation becomes facet. So I will read lower motor neuron as if my tongue is lying on the floor of my mouth, like lower motor neuron. Whereas in upper motor neuron paralysis, the tongue will be stiff because upper motor neuron paralysis increases the tone of the muscle. And so I will be speaking as if my tongue is projecting out of the mouth. Lower motor neuron. When there is a Parkinson's disease, the features of Parkinsonism like slow speech and tremor will take over my speech. So I will read like basal ganglia and associated brainstem nuclei. Whereas if it is chorea or a hyperkinetic movement, my movement will occasionally have sparks of hyperkinesis, like basal ganglia and associated brainstem nuclei, because there is chorea in my tongue as well, the buccal chorea. Ataxic dysarthria means the cerebellum is damaged and you get scanning speech. So instead of calling cerebellum, you will say cerebellum, because the function of cerebellum is to connect the syllable. That connection is lost. In motor neuron diseases like amyotrophic lateral sclerosis, there is simultaneous damage to upper and lower motor neuron. So you get a mixed flaccid and spastic dysarthria. And when along with a motor neuron manifestation, you have a cerebellar damage, like multiple parts of the brain are damaged, which happens in Wilson disease due to copper deposition, you can have a mixed ataxic spastic flaccid dysarthria. So this is a very good functional classification of dysarthria and helps you localize the site of the lesion. So is this clear to everyone? So as a summary, aphasias are abnormalities of language that are not due to defect in vision or hearing or motor paralysis. The common types of aphasia are Broca's, Wernicke's, transcortical motor and sensory, conduction, global and anomic. Dysphonia is a disorder of voice production, whereas dysarthria is a disorder of articulation. And with this summary, let us try the questions that we started with. So the vibration of vocal cord are best described as. Wonderful, the answer will be quasi-periodic. Dysphonia in Renkes edepa in smokers is due to. Yes, it is due to abnormal vocal cord vibration. That is because of the edema. What is an example of a bilabial English consonant? Wonderful, the answer is P. P is bilabial. F is labial, but it is actually a frictive labiodental. So P will be the right answer. Spastic dysarthria occurs in. Wonderful, in the upper motor neuron paralysis. Finally, mixed spastic flaccid dysarthria occurs in motor neuron diseases like amyotrophic lateral sclerosis. Wonderful. So I hope you enjoyed the session, and do not forget to follow and subscribe the YouTube channel where all these videos will be uploaded.